Now, I have 5 minutes to show you, is it really OI, and conditions that can mimic OI. So when child is born and with the label fragile, you have this situation clinically and radiographically. Treating physician, the question is what is diagnosis? But parents' question is what is the future of my child? So have a look on this phenotype and the radiographs, and sometimes it's not easy to distinguish what it is. When OI could be in a question, when you have a severe type 3, when you have very mild type 1 at any age, even in children and adults, in some unusual forms like type 5. Here you can see the patients, female, age 4 days, and on this X-ray, can you distinguish, is it OI or is something different? Is it really OI? That is the question. But you can see deformed bones and lower limbs. And here you can see some radiographic features. You can see pathognomonic bone spurs and angulated diaphysis of lower legs in more detail here. And probably most of you, they will recognize that is, what is this? Any voice? More radiographic features? Some radiolucency in metaphysis? So I won't keep you perplexed for a long time. Here you can see something similar to rickets. Anyway, there is a genetic error. Yeah, right. And as you can see, some alkaline phosphatase is deficient, and the end result is normal production of bone, but inadequate mineralization, as you can see. So this is hypophosphatasia, and orthopedic treatment is not available, but recently enzyme replacement as phosphatase alpha is introduced. This is classification, and we usually can see prenatal benign form or infantile form. Here you can see also childhood, adults, and other types of this disease. We have in our department 2 patients which has a spontaneous improvement of skeletal defects, so this is also possible. And so this is the first thing you have to differentiate from severe type of osteogenesis imperfecta. How to make a diagnosis? Again, screening for mutations in the tissue, non-specific alkaline phosphatase is essential to confirm. Other diagnoses are rickets or achondrogenesis. And the common differential diagnosis is non-accidental injury. And what is different? Fracture pattern and localization of fracture. So multiple rib fractures in an infant would be an unexpected finding in OI. But olecranon fractures or transverse diaphyseal fractures or humerus or femur are more likely to indicate OI. This is from the literature. You can see some features of OI, more probable, apophyseal avulsion fractures, long bone deformities, multiple Bormian bones, osteopenia, Pomme-Corn classification, all in OI type 3. But on non-accidental injury, on opposite, you have classical metaphyseal lesions, complex skull fracture, posterior rib fracture, and spinosus process fracture as well. This is very important to differentiate non-accidental injury and OI because it can cause lots of trouble for the families. And key to success is simultaneous work on both diagnoses, OI and non-accidental injury. And you should enlist everything what you can get from genetics or some other appropriate authorities. This is some flowchart or algorithm from the Cruz, Richard Cruz from Wilmington. He published that 20 years ago, and this is used in Wilmington, I think. Bill can confirm if they still use it. So fracture at the time of diagnosis, also you should look for the age of the patient and the family history. Age has limited reliability, and only 10% of the patient do not experience long bone fracture during childhood. And mean age for OI type 1 are 6.9 years when they have a fracture. Family history is also in type 1 is not very predictive. In adult age, also you can miss type 1, and there are some difficulties in diagnosis because you can see atypical or unclear postmenopausal osteoporosis. Vertebral fractures are typical after minor trauma, and a key to diagnosis is skin fibroblast culture or bone biopsy. And this is one case report when in adulthood in childhood type 5 can be a diagnostic difficulty, and just short summary of this paper. There was no trauma, but limitation and pain in elbow. And after they did the radial head excision, there was a worsening of the symptoms. Here you can see another case where you can recognize hyperplastic callus formation, and that should be some kind of warning for you to recognize type 5 OI. And what is typical, it's this membrana interossa ossification, and of course hyperplastic callus somewhere else. So you should be careful not to miss type 5 OI, which is not very frequent and it's easily to miss. Very shortly, I will go what was already spoken this morning in a skeletal dysplasia instructional lecture about osteopetrosis. You have this typical vertebra sandwich type appearance on an X-ray. This is called osteopetrosis. Etiology is unknown. There's some role of thymus, defect in function of osteoclast, and you can see bone within the bone and sandwich appearance of vertebra on lateral X-ray. Another disease also mentioned this morning is pycnodysostosis or dysostosis petrosans. Pycnos means dense. This is defective. Osteon is bone. It also is known as a malady of Toulouse-Lautrec. And those are just short summary of the clinical feature. And pycnodysostosis also can go with short stature, deformity of extremities, and frequent fractures, and so on. You can see the short terminal phalanges, short stature, one clinical exam from our practice. So this is take-home points. In severe OI, which represent type 3 OI, you should distinguish OI from hypophosphatasia. In a mild type 1, you should distinguish in children non-accidental injury. In the unusual forms like type 5 or osteopetrosis or pycnodysostosis, you should also distinguish from OI. And this is from me for this talk. Thank you.